All right, let's dive into one of the absolute most important topics you'll ever cover as a PA student, heart failure. I know it can seem super complex, but we're going to break it down. By the end of this, you're going to have a high-yield framework that'll not only help you crush your exams, but, way more importantly, help you take amazing care of your patients.
So, why do we care so much? Well, look at this number. In the United States alone, nearly 7 million people are living with heart failure. This isn't some rare textbook condition. It's a massive health challenge, and you are absolutely going to be on the front lines managing these folks every single day of your career.
So here's our game plan. We're going to start with the absolute basics. What even is heart failure? Then we'll get into left versus right-sided failure, which is all about the clinical signs you'll see. We'll cover how to stage and classify it, how to diagnose it, and then the really good stuff, the 4 pillars of treatment for HF-REF and what to do for HF-PEF.
Okay, let's get one thing straight right out of the gate. Heart failure isn't really a single disease. You should think of it more like a clinical syndrome. It's kind of the final common destination for a whole bunch of other problems, like a heart attack or years of uncontrolled high blood pressure.
At its absolute core, the problem is simple. The pump is failing. It just can't get enough blood out to the rest of the body to meet its needs. And when that happens, the body freaks out and kicks in all these backup systems, which, ironically, just makes things worse in the long run by causing fluid retention and putting even more strain on that already tired-out heart.
So the pump can fail in 2 main ways. On one side, you've got systolic failure. Just think weak pump. It can't squeeze hard enough. We call this HF-RF, or heart failure with reduced ejection fraction. Then you have diastolic failure. Think stiff pump. The squeeze might be fine, but the ventricle is so stiff it can't relax and fill up properly. We call this HF-PEF, heart failure with preserved ejection fraction. And get this, about half of all heart failure patients fall into this stiff pump category.
Okay, now let's get into the symptoms your patient will have. It all comes down to which side of the heart is failing. Seriously, just think of it like plumbing. Where is the fluid backing up? This is going to be the key to your physical exam.
So let's think it through. If the left ventricle, the big workhorse, fails, it can't pump blood forward to the body. So where does that blood go? Well, it backs up into the circuit right behind it. And what's right behind the left ventricle? The lungs. This is why you get all those classic lung symptoms: shortness of breath, trouble breathing when lying flat, and of course those crackles you hear with your stethoscope.
Now, what if the right ventricle fails? The logic is exactly the same. The blood can't get pumped forward into the lungs effectively, so it backs up into the circuit behind it. And what's behind the right ventricle? The rest of the body. And that's where you see all those signs of fluid overload: the big neck veins, or JVD, the swollen legs and feet, the congested liver, even fluid in the belly.
And this right here, this is a huge clinical pearl. Write this one down. While right-sided failure can happen by itself, the #1 most common cause is actually pre-existing left-sided failure. It just makes sense, right? The pressure backs up from the left side through the lungs, and that pressure eventually just overwhelms the right ventricle, causing it to fail too.
Okay, this is super important and a place where students get tripped up all the time. To manage heart failure, we use 2 different systems, and they are not the same thing. They answer 2 totally different questions. One is about the progression of the disease itself, and the other is about how the patient feels day to day.
First up, the ACC/AHA stages. This is all about the structure of the heart and the disease progression. And what's really interesting is that you can be in stage A or B without having a single symptom. Stage A just means you're at risk, say you have hypertension. Stage B means you have some structural damage, maybe from a past heart attack, but you still feel fine. Once you develop symptoms, you're stage C. And here's the key: you can't go backwards. You're stage C for life. Stage D is, of course, the end stage.
Now, the NYHA classification is totally different. This has nothing to do with the structure of the heart. It's all about how limited the patient is by their symptoms right now. And here's the huge difference. A patient's NYHA class can get better. With great treatment, we can take someone from being a class 3, where they get short of breath just walking to the mailbox, and get them back to being a class 2. It's a snapshot of how they're feeling today.
Okay, so let's play detective. Your patient comes in, they're short of breath, their ankles are swollen. Your history and exam are screaming heart failure. What's next? How do you actually confirm it?
These are your go-to tools. You're going to start with some labs, specifically a BNP. This is a hormone that the heart's ventricles release when they get stretched out. You'll get an ECG to look for clues like a past heart attack. And then you're going to get some pictures, a chest x-ray, and, the most important one of all, an echocardiogram.
Okay, PANCE Pearl alert. This is a big one. A BMP level below 100 has a really, really high negative predictive value. What does that mean? It means if your patient is short of breath, but their BMP is, say, 50, it is super unlikely that heart failure is the cause of their problem. It's a fantastic test for ruling it out.
So remember the workflow. The BNP is amazing for ruling out heart failure, but the echocardiogram is what rules it in. And even more critically, the echo is what tells you the type of heart failure by measuring that left ventricular ejection fraction, or LVEF. This single number is how you'll know if you're dealing with a weak pump, HFrEF, or a stiff pump, HFpF. And that is everything when it comes to treatment.
All right, now for the main event. If you learn one thing about treating HFrEF, heart failure with a reduced ejection fraction, this is it. We're talking about the 4 pillars of guideline-directed medical therapy. These are the medications that have been proven, without a doubt, to help people live longer.
Pillar number 1 is attacking the renin-angiotensin-aldosterone system. Our number 1 choice here is a drug class called an ARNI. It does 2 things. It blocks the bad stuff from that system while also boosting the body's helpful hormones. If you can't use an ARNI, then an ACE inhibitor or an ARB is your next best bet.
Pillar number 2, an evidence-based beta blocker. And I can't stress evidence-based enough. Not just any beta blocker will do. You have to use one of the big 3, carvedilol, metoprolol succinate, the long-acting one, or bisoprolol. These meds basically protect the heart from being in a constant state of fight or flight.
Okay, pillar number 3 is an MRA, like spironolactone. These drugs block a nasty hormone called aldosterone, which makes the body hold on to salt and water and causes scarring in the heart muscle. Adding one of these gives a huge survival benefit.
And the 4th and newest pillar, an SGLT2 inhibitor. You might know these as diabetes drugs, but it turns out they are incredible for heart failure patients, even those without diabetes. They are absolute game changers for reducing the risk of dying or being hospitalized.
Okay, seriously, screenshot this slide. For your boards and for real life, it's not enough just to know the drug classes. You have to know that we start these meds at a low dose, but the goal is always to titrate up to the target dose. Why? Because these target doses are where the clinical trials showed the biggest benefit in keeping people alive. All right, let's wrap this up with a few absolutely critical pearls. We'll talk about what drugs to avoid, like the plague in HFEF, and then we'll pivot to how we manage that totally different beast, HFpEF. This is another classic board question topic. Knowing what not to give a patient is sometimes more important than knowing what to give them. NSAIDs like ibuprofen, they make you retain salt and water. Terrible. Most calcium channel blockers actually weaken the heart squeeze, and certain diabetes meds, the TZDs, can make fluid retention worse. Just avoid them. This slide sums it up perfectly. For HFrEF, the weak pump, our goal is to reduce mortality with those 4 pillars we talked about. For HFpEF, the stiff pump, the game is different. We don't have that same mortality-reducing toolkit. So the focus shifts to reducing hospitalizations, and SGLT2 inhibitors are a big player there now, managing their symptoms with diuretics and just aggressively going after the other problems driving the disease, like high blood pressure and diabetes. And listen, you can prescribe all the fancy drugs in the world, but don't ever forget about patient education. This is how you keep people out of the hospital. You have to teach them to watch their salt, to weigh themselves every single morning to catch fluid gain early, and to understand why taking their medicine every day without fail is so important. So what's the big picture here? Heart failure is absolutely a serious disease, but it is not the death sentence it once was. We have an incredible toolkit now. The challenge for you, and honestly, the opportunity for you as a future PA, is to master these concepts, use these evidence-based therapies, and completely change the outlook for the millions of patients who are counting on you.